Welcome to Clinical Reasoning Rounds, Episode 8. Today we explore how diseases signal their arrival. From long-standing gut issues to sudden chest pain, every condition sends a warning. Our goal is to read these signs earlier. This video is for education only and not medical advice. Let's begin our rounds. We follow a structured 6-beat format for each case. We start with the patient's history, move to examination, then analyze investigations. You will then pause the video to commit to a diagnosis before we reveal the answer and clinical pearls. Remember, the goal is to spot the earliest warning sign in every story. Here is our case board for today. We have 5 patients, each with a distinct clinical history, from a 74-year-old with persistent abdominal pain to a young man with sudden chest pain. Each case contains a hidden warning. We will tackle these one by one, starting with Case 1. Case 1. A 74-year-old woman presents with 10 years of colicky lower abdominal pain. It was a familiar, manageable discomfort, but this week, the nature of the pain changed. It became constant, accompanied by fever and an absence of bowel movements. When a chronic complaint changes character, it demands our full attention. Let's review the history. The patient has a 10-year history of lower abdominal distress. 4 years ago, she experienced rectal bleeding, and imaging revealed diverticula in her sigmoid colon. Now the pain is persistent, and she feels unwell. This is a crucial pivot point in her clinical narrative. On examination, she has a fever of 38.5 degrees. Her vitals are otherwise stable. Palpation reveals tenderness and a vague mass in the left iliac fossa. Importantly, there is no guarding or rebound, indicating no perforation, and bowel sounds remain normal. Something is inflamed, but it is currently contained. Lab results show an elevated white cell count of 15.6 and a C-reactive protein of 56, confirming significant inflammation. The imaging history confirms the presence of diverticula in the sigmoid colon. We have a clear clinical picture, but we must also consider conditions that could mimic this presentation. It is your turn. Based on the history, physical findings, and labs, what is your diagnosis? Also, name the 2 potential rivals that could mimic this clinical mass. Finally, what is your plan for imaging now and in the future to ensure her safety? Pause the video and consider these questions. The diagnosis is acute diverticulitis. This occurs when one of her pre-existing diverticula becomes inflamed. It is a common condition in older adults, often linked to long-term low-fiber intake. Crucially, because there is no peritonitis or obstruction, she can be managed medically rather than surgically at this stage. We must remain vigilant against mimics. Colon cancer and Crohn's disease can present with similar symptoms, including a palpable mass. Because a benign diagnosis can sometimes hide a more dangerous underlying condition, we proceed with a CT scan now for acute management and schedule a follow-up colonoscopy to definitively exclude malignancy. Management involves broad-spectrum antibiotics, fluid resuscitation, and bowel rest. Surgery is reserved for severe complications. Once she recovers, we will transition her to a high-fiber diet. The key pearl: always be wary of diagnostic complacency. When a familiar condition changes, reevaluate and ensure you have ruled out life-threatening rivals. Case 2. A 36-year-old teaching assistant presents with severe, resistant hypertension. Despite being on 4 different antihypertensive medications, her blood pressure remains high at 180/102. In such a young patient, we must look beyond essential hypertension and identify the underlying driver. This patient's hypertension was identified 2 years ago and has been notoriously difficult to control. She has no family history of early hypertension, and her pregnancy history was unremarkable. However, her significant smoking habit is a key factor to consider as we investigate potential secondary causes for her elevated pressure. Our examination is a deliberate process of exclusion. We check pulses to rule out coarctation, inspect the skin for markers of neurofibromatosis, and inquire about symptoms suggesting a pheochromocytoma. A normal physical exam here is highly informative. It systematically narrows our differential diagnosis by ruling out these specific, rare causes. Investigations reveal a slightly elevated creatinine and urea. Her potassium is normal, which is interesting given she is taking a potassium-wasting diuretic, effectively making certain hormonal causes less likely. The urine is clean, ruling out glomerular disease. This points us toward the renal vasculature. What vessel study should we perform next? Pause the video and consider these questions. After ruling out other causes of secondary hypertension, what specific disease do you suspect in this 36-year-old? Think about the vascular findings and the treatment that offers a potential cure. transforming her long-term management. The diagnosis is fibromuscular dysplasia, or FMD. This condition causes narrowing of the renal arteries, leading the kidneys to falsely signal for higher systemic pressure. The renal angiogram classically shows a, quote, string of beads pattern. It is more common in young and middle-aged women and is strongly associated with smoking. The definitive treatment is percutaneous transluminal renal angioplasty. Unlike atherosclerosis-related stenosis, which is rarely cured by this procedure, FMD often responds exceptionally well. A simple balloon dilation can restore flow and frequently allows patients to stop their antihypertensive medications entirely. It is truly one of medicine's success stories. Key pearls from this case. Resistant hypertension in a young person demands a search for secondary causes. Perform a systematic examination to rule out specific conditions. Remember, normal findings in certain tests, such as potassium levels while on a thiazide, are valuable data points in your clinical reasoning process. Case 3. A 34-year-old woman presents with tender red lumps on her shins and forearms. This is a classic dermatological presentation that acts as a billboard for underlying systemic disease. We must look beyond the skin to identify what is truly driving this inflammatory response. Her history reveals a 2-week progression of these painful skin lesions, accompanied by systemic malaise and joint aches. Crucially, she reports 2 years of recurrent mouth ulcers and intermittent gastrointestinal symptoms like abdominal pain and diarrhea. We are looking for a diagnosis that links these disparate findings. Physical examination confirms the tender, bruise-like nature of the nodules, which are healing from the center outward. Her joints show no signs of active inflammation, indicating arthralgia rather than arthritis. The rest of her physical exam is unremarkable, suggesting the primary pathology is linked to her chronic history. Laboratory investigations show a significantly elevated ESR, indicating systemic inflammation. We performed a chest X-ray to rule out sarcoidosis, which often presents with similar skin findings, but the result was normal. This focuses our attention back to her long-standing gastrointestinal history. It is your turn. Based on the skin findings and the 2-year history of mouth ulcers and gut distress, what is the rash? Furthermore, what is the underlying sender of this message? How would you confirm this diagnosis definitively? Pause the video to formulate your answer. The skin condition is erythema nodosum. It is not a disease itself, but a messenger of inflammation. It is characterized by tender, red, deep skin nodules on the shins that evolve through bruise-like colors. While it can be idiopathic, it almost always signals an underlying process in systemic cases. The sender here is Crohn's disease. Her 2-year history of mouth ulcers, abdominal pain, and diarrhea is highly suggestive of undiagnosed inflammatory bowel disease. This is confirmed via small bowel imaging and a colonoscopy with biopsies. Treating the underlying Crohn's will resolve the associated skin lesions. Remember these pearls. Always search for the sender when you encounter erythema nodosum. Treat the primary disease to stop the skin message. Finally, learn to connect seemingly unrelated symptoms across organ systems, like mouth ulcers and gut issues, to uncover a single systemic diagnosis. Case 4. A 73-year-old woman presents with severe breathlessness. Her history is marked by a slow decline over 2 months, unexplained weight loss and frequent nosebleeds, culminating in a rapid 4-day crisis involving cough and decreased urine output. We have a multi-system presentation to solve immediately. We must differentiate the timeline. The 2-month period represents a long-standing, insidious process, while the last 4 days represent an acute, life-threatening emergency. The combination of nasal, lung, and kidney involvement should immediately trigger a high index of suspicion for a specific class of systemic disease. Examination reveals a critically ill patient, tachypnic, febrile, and centrally cyanosed. We see a purpuric rash on her ankles, signifying inflammation of small vessels. Although her chest shows coarse crackles, her normal JVP suggests this is not typical heart failure. This is a vasculitic emergency requiring urgent intervention. Case 4. We examine the investigative data. Her creatinine is at 832, indicating renal failure. Potassium sits at 6.6, dangerously affecting heart rhythm. An arterial pH of 7.18 confirms severe metabolic acidosis. These numbers describe a catastrophe. The lungs are filling with blood, and the kidneys are inflamed. Pause the video. You have 2 jobs. Define the syndrome and identify the most likely underlying disease. Which single clue distinguishes her case from its closest rival? Second, define the emergency sequence for her potassium. The order matters. then state the tests and treatment that can confirm and ultimately rescue her. The diagnosis is granulomatosis with polyangiitis, or GPA, a form of small vessel vasculitis. The defining syndrome is pulmonary renal failure. Her 2 months of nosebleeds are the crucial clue that identifies GPA, differentiating it from microscopic polyangiitis. ANCA antibodies typically unify this disease family. Management follows 3 phases. First, save the patient. Give oxygen and treat the potassium of 6.6 with intravenous calcium gluconate to stabilize the heart, followed by insulin and dextrose. Second, prove the disease with blood ANCA testing and renal biopsy. Finally, rescue with plasma exchange, steroids, and cyclophosphamide. 3 pearls. Pulmonary renal syndrome is an emergency where speed is life. Second, never dismiss recurrent nosebleeds as a mere nuisance in a systemically ill patient. They are often an early warning. Third, always treat the potassium before you finish the paperwork. The heart will not wait for your biopsy results. Case 5. A 17-year-old boy presents to the emergency department. 6 hours ago, a sharp pleuritic chest pain struck his right side. He struggles to breathe. Crucially, he reports years of unexplained back and arm pains, previously dismissed and managed at home with over-the-counter painkillers. Tonight, his history finally speaks. This teenager's history contains 4 distinct threads. Tonight, he faces an acute, sudden chest pain. Preceding this, a sore throat acted as a trigger. For years, he lived with episodic bone and joint pain, an unread letter in his medical history. He is of African Caribbean heritage, a population with specific genetic predispositions. Examination is revealing. He is tachypneic at 28 breaths per minute and visibly cyanosed, yet pale from anemia. Remember this clinical pearl. Cyanosis is harder to see in anemic patients because there is less hemoglobin to turn blue. Visible cyanosis in a pale patient means his hypoxia is severe. Investigations confirm his distress. Hemoglobin is 7.6, and oxygen saturation is 7.2. Yet his chest X-ray is clear. This combination of severe hypoxia and pleuritic pain on a clear film demands a focused differential, including pneumothorax, pulmonary embolism, and the suspect we are now uncovering. Pause the video. Based on his background, the episodic pains, and this acute chest crisis, what is the diagnosis? What were those previous pains? Detail the definitive confirming test, the 5 pillars of acute management, and the specific transfusion maneuver required when a patient is in a severe crisis. The diagnosis is sickle cell disease presenting with a chest crisis. His childhood pains were vaso-occlusive crises. The disease results from 1 amino acid substitution, valine for glutamic acid, causing red cells to sickle. These rigid cells cause infarcts in bones and lungs. Infection or dehydration often trigger these life-threatening events. Sickle cell disease has many complications, including aseptic necrosis, sequestration crises, and hyposplenism. We prove the diagnosis with a blood film showing sickled cells and confirm it definitively using hemoglobin electrophoresis. The level of fetal hemoglobin is important, as it helps determine the patient's long-term disease severity. Management rests on 5 pillars: rest, intravenous fluids, oxygen, effective analgesia, and antibiotics. For severe chest crises, a partial exchange transfusion replaces sickled blood. Long-term management involves an expert multidisciplinary team and hydroxyurea, which raises fetal hemoglobin to prevent future crises. Remember, recurring unexplained pains in youth always deserve a formal diagnosis. Let's summarize our 5 cases. Whether it's a changing abdominal complaint, resistant hypertension, shins displaying a billboard for disease, failing organ systems, or childhood pains finally named, the lesson is clear. Recurring issues or changing patterns are warnings. Read them early, and you change the outcome for your patient. Rounds are complete. We have navigated 5 distinct warnings today, from diverticulitis and fibromuscular dysplasia to Crohn's, GPA, and sickle cell disease. Every symptom is a clue if you are willing to read it. Thank you for joining me. Share this video with a colleague and keep refining your clinical reasoning.